Maybe I'll just hold it. No? Okay. How about here? Not me. All right. Well, I think we should start. I think most of us are here. Let me introduce myself. I'm probably the only person on this panel who has no relationship to treatment as prevention trials. I'm Megan Murray. I'm an infectious disease doctor turned epidemiologist. In the context of this particular panel, I have to say I was an undergraduate in philosophy, so I bring some interest in that as well. But this topic is hugely interesting to me. I'm actually a former member of the Department of Epidemiology here, and still an affiliate, and now at the Department of Social Medicine and Global Health at the medical school, and have been working for many years on tuberculosis and looking at transmission dynamics, modeling actually interventions. In TB, treatment as prevention is a very long-standing paradigm. It's actually the main form of control for tuberculosis, and has never been subjected to a trial for that, as far as I know. So it's fascinating to see this play out in the HIV world. And I think there's lots of questions that we can bring to it, and I know some of them will be answered today. So I'm thrilled to be here, and I'm also thrilled to introduce Till, who's going to introduce everyone else. Till is an associate professor in the Department of Global Health, an economist and a physician, and has had a long-standing, and a program director at the Africa Center in South Africa. And he's recently co-authored a very important paper on an observational study, an ecological study of the effects of treatment on transmission in South Africa. So, Till, could you pick up from there? Oh, no, I'm keeping.
Great, thank you, Megan, for the excellent introduction. And my first chart is already, I had precisely the same idea to start this off. So treatment as prevention is a very old public health principle, and we've used it and thought about it in public health in many different arenas, and certainly TB is one. STI in general are an important application of treatment as prevention principles. So there is a long-standing history of that thought. And as Max also pointed out to me in a conversation recently, in the HIV field, of course, it is a very old and early intervention that we thought about using treatment to prevent the onward transmission from a mother to her child of the HIV virus. And there is thus philosophical almost underpinning in HIV of that concept of treatment as prevention. And really, when Mike Cohen published his study, there was already a long-standing debate and history of mathematical modelers examining treatment as prevention hypotheses in theoretical models with often extreme assumptions that will not be met in real life. And here now was a study that showed, at least in one very particular population, serodiscordant couples who are stable. And you must imagine how particular they are. They come together, maybe holding hands, and jointly join a trial, a randomized controlled trial, where they're committing to be together for some years within that trial. And thus a very particular population, but also a population we really care about. People who are serodiscordant have mutually disclosed. That's another specific characteristic, I think, of this trial population. That is a rarity, of course, in many settings, in sub-Saharan Africa and in the United States, because disclosure can go hand in hand with abuse, with danger to a person's life, and is something very hard to do, also simply in an intimate relationship. But in this population, and that's this major finding that pushed the entire field ahead, HIV transmission can be nearly eliminated or virtually eliminated if we treat the partner who is HIV infected and continue treating that person irrespective of CD4 count, irrespective of disease stage. And of course, currently, still the paradigm in most sub-Saharan African countries, and the United States has moved away from that, is to treat in relatively late stages of the disease. And we know that in practice also people come quite late in their disease course, often driven by symptoms, to the treatment centers. So mathematical modelers have looked at this question, and some have claimed we can eliminate the HIV epidemic through treatment as prevention, which is essentially treating anybody we can find and being very active in finding HIV positive people, trying to find them in early disease stages, ideally immediately after infection. If we could be perfectly executing tasks, we would find the person on the day they are infected. Of course, that's not realistic and poses a major issue also to the effectiveness of tasks, because we know that viral load and transmission risk is highest immediately after infection or in the early weeks and days after infection. And we need to find people as early as possible, especially in those early stages when they've also, through their own acquisition, just signaled that they are at danger of transmitting, because they're sexually active, and they're sexually active in an unprotected way, which has led to their own infection. So there is hope that even taking assumptions about who we can initiate, what the eventual coverage levels will be over all of treatment as prevention, we can make a substantial dent in HIV incidence. Here's from a Boston Medicine comparison study where Eaton and us and other colleagues estimated in a range of different mathematical models what could be achieved, and it is not elimination as the Ruben Kranich paper in the Lancet has found, but it is a substantial decrease in the HIV incidence rate, maybe by 60% or more. And here in a study, which is the first study of its kind in KwaZulu-Natal or in any sub-Saharan African setting, we followed about 16,000 individuals repeatedly over, on average, 6 years, measured their HIV status. So we really see the individual in their HIV acquisition experience, and as they turn from negative to positive, so we have an individual level, not an ecological level measure of HIV acquisition, and we relate that to local area ART coverage, and we find this very powerful finding that if around you, in your local community, where most of the sex partners in this community come from, when we ask people where's the sex partner, most live in a very small physical proximity to the key person. We see that it is very protective to live in a place where a large proportion of all HIV positive people are on ART. And that's an effect that is very similar to the mathematical modeling effects when you are in a community where 40% or more of people surround you who are HIV positive are on ART. Your HIV acquisition risk going forward is reduced by about 40% versus the person who lives in a community where 10% or less are ART covered. And we've recently repeated this study looking at household level ART coverage, and we see here that increasing the proportion of household members, and these are large households, on average 8 people or so, in the opposite sex who are covered with HIV when they're positive, can substantially reduce HIV acquisition hazards going forward. So going from 0 to 10%, adding 10 percentage point ART coverage to a household reduces the risk of future HIV acquisition of your opposite sex household members by 6%. So these are very encouraging results, but they are observational. There are also 9 ecological studies that have suggested that treatment as prevention can be a really important strategy to reduce incidence in those settings where it matters most. In sub-Saharan Africa, where we are still seeing these very high HIV incidence rates. For instance, in the Africa Center Demographic and Surveillance area, we see about 3 new HIV acquisitions per 100 person years. So in a situation where already 30% of the population are infected, the negatives are still facing this force of the epidemic, which is extremely high. And of course, we want to have effective strategies for those settings, but we cannot infer from the serodiscordant couple study that in a general population with instable couples, with migration, with frequent changes of couples, potentially with concurrency, with very different behaviors that are relevant for HIV acquisition, we can achieve what has been achieved in this one population of stable, long-term, mutually disclosed serodiscordant couples. So I do think we strongly need treatment as prevention trials to show if in health systems in sub-Saharan Africa we can achieve substantial incidence reduction with multi-study strategy where we try to find everybody who's HIV positive and irrespective of disease stage of CD4 count, initiate them as soon as possible on ART. And the world has agreed, and it has agreed with substantial monetary commitment to this cause. Here 4 large studies, and we are really lucky that out of these 4, 3 are represented in their PIs in this panel, which is fantastic, and maybe the first time actually that a panel has had all 3 PIs on 3 of these large treatment and prevention studies, jointly debating issues. And what is important here, I think, is that the funders have also committed with tens of thousands, tens of millions of dollars. The ENRS funds a study at the Africa Center that started in April 2012, and Deenan will talk about that. The CDC funds a study in Botswana that Max, of course, will talk about. And then there's the NIH HPPN study that used to be called PopArt in South Africa and Zambia. And finally in Swaziland, with support from the Clinton Health Access Initiative, the MaxArt study, and Velepi Okello will talk about this study. The reason why we think a panel is useful at this point in time is because, as you know, the guidelines in the HIV world are very dynamic, they constantly change. And that change has implications for policy, but also for science. And it creates a tension, I think, which needs to be debated, and we need to think about how, when policy presses ahead, we can still do science without doing science in a way that is unethical. And the United States has already declared in their latest HIV guidelines in July last year that everybody who is HIV positive, irrespective of CD4 count, irrespective of disease stage, should be recommended to be initiated. When the CD4 counts are above 500 or so, the recommendation is not at the strongest possible level, at a level of moderate strength, where the physician would counsel the patient to go on treatment, but also leave it to some extent to the patient whether or not they feel ready to go on ART. And then below 500, patients should really be on ART. And the United States, I think, is at the avant-garde here, and European countries will follow suit. WHO has, of course, last year in June pushed up their guideline recommendations to initiate people at 500, which is the higher CD4 count, as is currently the local standard of care in most sub-Saharan African countries. And this creates, to some extent, a worry for treatment as prevention trials because they've been powered under the 350 threshold. So the control group was assumed to be one that is exposed to the local standard of care for a few more years into the future when you initiated at relatively advanced disease stages under 350. And WHO has been powerful in setting these standards in sub-Saharan Africa and has really had an influence. And here we looked in the WHO repository of ART guidelines in sub-Saharan Africa. When the switch from 200 initiation to 350 happened, which countries followed suit or even presaged the guideline to initiate earlier in disease stage. And we see here as WHO in 2010 declares that patients under 350 instead of under 200 should be initiated. In Ghana in 2005, that was already the locally committed to standard of care. And most countries in sub-Saharan Africa followed suit, including those where treatment as prevention trials are happening. South Africa, Tanzania used to have a treatment as prevention study, no longer has that, and Botswana. So we see that WHO is likely norm setting within a few years of WHO announcing a change, countries follow suit, and that creates an important political pressure and a need for a debate. And the guidelines are quite extensive and would affect potentially the control groups in these large tens of millions of dollars trial initiative in a major way. Here, back of the envelope, we thought about, can we quantify what that means to the local standard of care, roughly based on some population-based CD4 count information going up to 500 will halve those who are eligible for treatment as prevention, but not eligible under the local current standard of care. So that would already make a major dent into the power that studies were powered under the 350 CD4 count initiation assumption have. And then, in addition, there are these other population groups, and they are also important. Of course, countries have moved to initiating all pregnant and breastfeeding women on ART for life, such as Malawi, and Tanzania has committed to that. So we would, in a sense, lose for the control group this population, children under 5 years of age with patients with active TB and hepatitis, and also serodiscordant couples. And if we are very honest or very strict in our definition of what a serodiscordant couple is, there are many of those in sub-Saharan Africa. And here are, from a Lancet ID study, estimates that 3/4 of all couples in all people in sub-Saharan Africa are currently in stable couple relationships, and that out of those who are positive, about half have a serodiscordant partner. So the missing link here to estimate how many people there are is HIV prevalence, which will of course vary by country, but it is a large pool who we would, if we're serious about adopting the WHO guidelines according to the serodiscordant couple eligibility criterion, need to initiate if countries adopt these guidelines fully. So that sets up the problem to some extent, and I think it will be interesting to hear from the trialists and then later on from the ethicists what are potential solutions, how we need to think about these issues. And the next speaker is Dylan. So Dylan Thiele is the director of the Wellcome Trust Africa Center for Health and Population Science in KwaZulu-Natal and a professor of virology at UCL.
Thank you. Thanks, Till, and thank you so much for the invitation to come here. It's a great end to my visit to Croy. As Till says, yeah, that's right. I've recently come to join the Africa Center, which is the Wellcome Trust funded center, and to join as PI to this trial that's ongoing, based at the Africa Center. A couple of things just to say before I start to this audience. First of all, we're very pleased that we have at the Africa Center a strong link to Harvard through Till, and we've had some discussions here. Some of you already, I've seen you at the Africa Center, and some will be coming to the Africa Center, and we really want to develop our strong partnership with Harvard, actually, as we move forward with our new scientific strategy. So I'm pleased to be here for that reason. The other thing is just to say something about HIV and treatment, and without knowing where each of you are in appreciation and understanding of HIV treatment per se, it's very interesting to ask how we've got to this stage of treatment as prevention. And you may ask, some of you may be thinking, well, why on earth is HIV not treated as soon as someone gets the disease? You know, what other infectious disease do you wait for years and years and years while the immune system is being damaged before starting treatment? And the reason really stems from the initial epidemic and when the very first drugs became available, such as AZT, which were very toxic drugs. And of course, at that stage, AIDS was a manifestation of HIV, and it was treatment of AIDS. Maybe in the same way as treatment of active TB compared to later TB. And it was only later that it was understood how much there's viral replication going on during the whole course of infection. And it was David Ho in the mid-90s that coined the phrase, it's the virus, that causes this disease. And the reason, even though drugs became available, and there's now something like 25 to 30 drugs available in North America and Europe available for treatment of HIV, it was the toxicity of those drugs which limited the extent to which they were used earlier on in disease, because it was a trade-off between toxicity and benefit for the individual, because people were thought to be generally quite well until developing AIDS with a lower CD4 count. And so that's been the origin of this starting treatment at a late stage, which we'd all agree, if you had the safest drug that could be slapped on as a patch, with no toxicity, would be treated much earlier in the disease. So that's the trajectory there. As people have explored HIV disease pathogenesis more and more, they've recognized that even at a higher CD4 count, there's a fair bit of immune dysfunction, particularly immune stimulation, which causes a number of manifestations of disease, not classified under AIDS-related diseases. And that inflammatory state is increasingly thought to cause morbidity, given that we've actually reduced mortality because of antiretroviral therapy in our environment. And so that's been the logic of slowly increasing the CD4 count at which treatment can be provided for. And there's some circumstantial evidence from observational studies that starting at a high level reduces morbidity, although there's a number of RCTs that are addressing that. So put that to one side, yeah, and so a lot of people say, yes, treat earlier. And now on the other side about treatment prevention is, and forgive me for just talking about this, I think it's important to sort of prelude. On the other side, of course, it's understood that if you reduce the amount of virus in the blood, then you reduce infectivity. And Tiller's identified the classic example of that is reduction of mother-to-child transmission, which is a highly effective use of antiretrovirals for public health purposes to stop transmission. So, of course, that now is coming there. Now, I think I would take the view that these are two different uses of antiretrovirals. One is for a public health approach to reduce incidence, and the other is about reducing more morbidity within the individual. And I think with these two different uses of drugs, there are different circumstances and different criteria that we should apply to using them. Having said that, I must say, particularly amongst the HIV physician group in the US, there's a very push saying, well, look, we all know that antiretrovirals is very good for the individual and it's good for reducing transmission. Let's just throw it around and treat everybody. Yeah, but I think this audience would appreciate that there are nuances between treating for the individual and treating for the population, just like immunization. So treating everyone as soon as they're diagnosed, we've got to take a view about trying to elicit, a response from those participants in those trials that this is actually for public health benefit, not necessarily for their own benefit, in the same way that we do with immunization. We all know that the sensitivity around immunization as things as uptake wanes and increases. So that's just a comment about this merging together of the use of antiretrovirals in a sort of blind way, whereas in fact we're asking different questions. So that's important. And of course, in a society where, in sub-Saharan Africa, where in the very recent past people have been dying, yeah, and every household would have, either within that household or through friends, have somebody who has died, and therefore antiretroviral therapy makes a huge difference. People who were dying are now alive. Okay, so that remains a big motivation to start therapy. That you're actually knowing that people are living rather than dying. So the motivation is to stop death in someone rather than saying let's stop transmission. And I just raise that because I think that will help the ethical discussion later. So sorry for that preamble. I've taken a little bit of time. I'll rapidly go through the next slide. So this is about this. I'm just going to describe this cluster randomized trial of treatment as prevention. Till has already described the environment in which the Africa Centre sits, just to say that there is a surveillance area and the clusters are recruited into the treatment prevention trial outside of our surveillance area. The importance of this is that although this is a cluster randomized trial out in this setting, we maintain the surveillance area which generates the sort of data that Phil's already shown about changing of instances ART rollout. So there's actually another, although it's not in the trial sense, another arm, there's a comparison group in the same environment of people treated under the normal Department of Health processes, and that's what is important. So the treatment, the trial as it is to evaluate feasibility, acceptability. So that's the pilot stage, which has just come to an end, and we've had funding from funding primarily from Gates to now move to the second phase, which is about effectiveness of this cluster randomized. There's funding from ANRS, the French group, and Germany. So in fact, unfortunately, these clusters are called, some of them are called French clusters and some are called German clusters. But in fact, they're all KZN clusters, as you imagine. This is it's home-based testing. So home-based testing with counselling and advice on prevention. dried blood spots are taken, which are tested for HIV, and then based on that positive result of infection, they're enrolled into the study, and the cluster randomization is identified here. First of all of these individual clusters having prevention services and HIV testing, and then being then that randomization continuing to ARV treatment according to the South African guidelines, which currently is CD4 count 350 to start, compared to immediate ARV treatment regardless of CD4 count. Here's the setting, and it's important this is an effectiveness trial. We're not providing treatment here, testing and treatment within the Department of Health, although it's in conjunction with the Department of Health. We have specific trial clinics which are taken out. So we've got to remember that, because the trials differ, that we'll hear about, differ in the degree to which the rollout is embedded within the Department of Health, and I just think we need to be aware of that when we come to interpreting results. So just on my final slide about some of the implications which would fuel the discussion later on. Well, because Till's already raised the question that the WHO guidelines have now recommended starting treatment at 500 rather than CD4 count 500 rather than 350. And of course, with that has the risk of diminution of the difference between the arms in terms of starting treatment regardless of CD4 count versus starting with treatment with CD4 350. It so happens that the South African government have recently taken the decision they're not going to impose those new WHO guidelines, at least for the next few years, primarily because they recognize that even now there's an inadequate coverage of HIV infected population in South Africa, even with the current guidelines. So that's an economic decision that's been taken, which in a way is fortuitous for the primary endpoint of the trial. So during this period of trial, there won't be that competing pressure of the Department of Health. Having said, and this raises the question of what WHO guidelines or any other guidelines are about. That actually, those guidelines that Till talked about, if you read them, the number of recommendations that are supported by strong evidence, they're very, very few indeed. The amount of expert opinion, or early stage data that informs those is major. So I think we just got to consider that about, and countries obviously have to do. The other thing is to distinguish between trials and health service and real life. And I've identified that within the TASK trial, we're bringing in mobile clinics into this. And of course, in both of these arms, there will be intensive monitoring, viral load, CD4 count monitoring. There'll be drug supply when it's needed and so on. But nevertheless, we work in an environment in the surveillance area next to the TASK recruitment sites, where there are drug stockouts still in South Africa. This happens where water supply often is turned off in clinics, where although viral load tests are recommended within South Africa and a lot of investments being made, what happens, of course, is that blood gets taken to get viral load. Viral load results come back and sit on a clinic in these nurse-led clinics and never get filed into any notes. So there's a real health operational component of this that is overcome by a trial. So, we just got to recognize that and we all know that trials are not necessarily related to what happens in real life. But regardless of that, in this setting, I think that's a really important point. So with that, I'll stop and pass over to the next speaker.
Thank you. So I probably should have said before you started that we should, because of timing, we want to open the floor for a live discussion at the end. I'm going to ask people to limit the time. So back 10 to 15 minutes.
Thank you. We just began a trial in Botswana, which is a combination prevention trial where I think it's fair to say the most important element is treatment of prevention. This is also called the HSPH trial. The HSPH in Botswana means many hands working together can do more than people working alone. It also means that you go together to collect words. And that's a group event, which is important because it's Botswana is considered a real delicacy. In Botswana, you can have the chocolate, a whole range of ways, but they're good. And so we actually, we actually started the trial a couple of months ago. We hope to go into, the goals of the trial are to see whether or not treatment of prevention can reduce cumulative incidence in 16 to 64-year-olds in Botswana over a 3-year period. To estimate population level uptake of HIV testing, as well as male circumcision, and uptake of ART for a range of reasons, including linkage to care, and estimate cost per infection averted. And finally, the most important component that I like to talk about is the use of treatment as prevention, specifically in that subset of people who have viral load RNA above 10,000 that don't necessarily qualify on the basis of CD4 count. And Botswana apparently is in the same situation as South Africa, where at least in their last meeting of the Ministry of Health Commission, they said they are not planning to go above 350 for CD4 criteria, despite the WHO guidelines. And in fact, they wanted to use more time to get up to 350. So, in the design of the study of the population, there's 30 communities distributed throughout Botswana, plus the randomization in a care-matched way with 15 pairs. And the interventions, as I mentioned, are rapid scale-up of testing services to identify who might need drugs, and with a target of greater than 90% adults aged 16 to 64 on that. Rapid scale-up of antiretroviral drugs for people who qualify based on the 350 CD4 cutoff for WHO scale 3 for age-defined illness type disease. Rapid scale-up of, as I said, for ART in people who have viral load about 10,000. Rapid scale-up of male circumcision for people between 16 to 49. Rapid scale-up of prevention of mother-to-child transmission, tumor prophylaxis with ART, and week plus for continuing breastfeeding mothers after they started on ART. And some of the uptake for things like preventing mother-to-child transmission is extremely high in Botswana to begin with, so there should be no problem at all getting above 95% on that. Now, there's about 180,000 people in the 30 villages. They have about 6,000 people per each. They were deliberately selected as far enough away from urban areas so that we hoped they would be less likely to pick up incident infections in urban areas as opposed to their own village. There's approximately 9,000 patients in an incident cohort that represents 20% of the population of all 30 villages, and approximately 1,800 participants that will be in what's called a closed clinical cohort to look at outcomes in those people who got ART on the basis of high viral load only, and otherwise is not qualified for CD4 as compared to those in the what we call enhanced care and control villages do not get that intervention. This is the places in Botswana where the 30 villages are. As I mentioned, it's deliberately selected to be far enough away from urban areas. And I would just say that the two features that in my own mind distinguish this particular treatment and prevention initiative above most of the others that I've heard of. Number one, the key components beyond the things you should do anyway, like linkage to care and testing when people have to identify the positive, is intervention based on high viral load. Why? Because we know that transmission is correlated most closely with viral load. The higher the viral load, the more likely you are to transmit that virus to infect someone else. And most, people say that CD4 levels are not as closely correlated with transmission as with viral load. And indeed, some of us argue that had the viral load test not be available long before viral load tests were available 10, 20 years ago, viral load might be the first standard for putting people on therapy as opposed to CD4. But that's not the way it happened because of the availability of the technology. And finally, our incidence analysis for efficacy is based on trying to estimate the fraction of new infections that occurred within the village where the intervention took place. To try to distinguish and estimate by viral genetic, phylogenetic linkage, the fraction of new infections that came from somebody else in that village, because obviously if that village had treatment prevention, we would hope that the effect would be village-wide and it would decrease the incidence in that particular village. It can't do anything for individuals from those villages who got infected in cities or other countries or other villages or someplace else. So we have two mechanisms of incidence. One is people who got infected in their own village, and the other is incidence rate overall. And this is just a phylogenetic tree of how we determine the fraction of new infections that came from that village as compared to came from outside the village. And I should add that for many people, the OFA2 study, which we and many others were part of, really convinced the world that this works because it was most dramatic by far, in fact, it was only in the sense of showing that treatment as prevention could work between couples if you could verify by viral phylogenetic linkage that the uninfected partner in that relationship got infected from the partner who had drugs. So this is just an expansion to try to use that same criteria of determining what fraction of new incident cases got infected from within that village where the treatment of prevention is occurring beyond just the situation of individual public safety.
Thank you, Tim, for the introduction. And it's good to be back to my old school. I graduated here in 2012 under the Health Policy Management Department. So it's quite difficult to summarize everything in a few slides, 5 slides, but I think I'll just try to bring out some of the issues on the ground since I'm working with the Ministry of Health. I was just thinking around these studies. I'm with my colleague here, Fiona and Chai. So perhaps as a brief background on Swaziland, Swaziland is that small country looks like a dot in many places on the map, surrounded almost entirely by South Africa, but on the east we border with Mozambique. So really it's one country that has seen a very, very high prevalence of HIV, probably the highest, has been the highest. I don't know if Botswana is taken up. Sometimes I hear those kind of talk, but I know that we are facing a very serious problem in the country. And however, we've also seen a good uptake in terms of HIV testing services and ART services. And at this point, we are one of the few countries that have reached what UNAIDS calls universal access to care and treatment. We've reached more than 80%, up to 90%. And so we, as Minister of Health, reached a point where we were saying we are looking to do more. We have to get more aggressive. We can't just sit there and say, we've reached universal access. So the issue of trust for us was a discussion that was welcome as Ministry of Health. We're working with our partners. So under MEXAT is just a project within our national program for antiretroviral therapy, which is run entirely by Ministry of Health. But MEXAT is just composed of funding that we got from the Dutch postcode lottery, and then it consists of a consortium of partners who are working in the country. We are looking at 3 keys within the MEXAT project. The first key being plugging in a leaky cascade of making sure that people who test, or people are mobilized from communities to test. When they test, they are linked to care and treatment, and after being linked and enrolled in care, they are retained in care and treatment. So for us, we find that that's a very important cascade, that we must make sure that we have the right strategies to plug in those leaks in that cascade. So that's the first key of the MEXAT project. The second key has a social science piece that looks at the reasons why people don't want to link, why people behave in certain ways in terms of accessing HIV services. And then the key 3 of the MEXAT project is this MEXAT implementation study that is now looking at how can we strategically use antiretrovirals for treatment and prevention of HIV infection in Swaziland. So MEXAT really, we are saying we want to maximize ART for better health and 0 HIV new infection. So we still emphasize improved outcomes of people who are taking ARV medication. So I'll just summarize the study objectives. We want to determine the feasibility of implementing an immediate Art for All strategy within government-managed health systems. So looking at acceptability, uptake of HIV testing and counseling, and ART uptake. So there will be also a social science piece there to understand why people are not willing to take up these services of immediate Art. Then assessing outcomes, we think that we want to know if the outcomes that we get, if people are initiated Art immediately, will be the same as what we are getting now, because we have very high retention rates. It's 6 and 12 months within our national program. And so also want to look at affordability and scalability of the strategy within the government system. So looking at issues around cost and cost effectiveness. And of course, the social science piece will be moving with us in every aspect, with different questions being asked along the way. So the endpoint that we are looking at is retention at 3, 6, and 12 months, and the secondary endpoints of ART uptake, adherence, drug resistance, tuberculosis incidence, and cost per patient per year. So the study design is in the form of a randomized stepwise open enrollment. So basically the facilities is writings of site 1, 2, 3, 4. These are health facilities that will enroll in. So we've selected around 15 sites in one region in the country. So the enrolling sites in a stepwise, they'll have a period. The T is a transition period where the sites will be taken through how to transition from the current guidelines into offering immediate art for their clients. And we're looking at adults more than 18 years of age. So the benefits of this web design is that we think we will achieve statistical efficiency because the same facility could act as its own control when we compare the data of before the transition and after the transition. The logistical efficiency will also be improved because we won't have to have a huge study team. So the same one study team will be following one facility after another and helping each of these facilities to transition into the immediate art for each of those facilities. And then removing potential bias in selection of the intervention. And so some of the practical issues, there's more on if there are questions later, with Fiona we can answer. But I was thinking of the practical issues for this discussion is that this study is different in that it's in full partnership with Ministry of Health. So the questions were first asked by us as Ministry of Health of what would it take for us to move to PASS? Is it really that difficult for our country to do this? We know that HPTN 052 was a clinical trial, but what about applying the same approach on the ground? Will we get the same kind of results or similar results? Then we are moving, and we're also thinking around moving to the new treatment guidelines. I think we have reached that point where we can't stay at 350. We have to increase the enrollment through opening up the eligibility. So our technical working group, we have met and we have decided that we will move to 500 as a cut-off. And in addition to that, we are going to move to B+, which is immediate art for all pregnant women and breastfeeding women, children under 5 years. Currently, we are treating children under 2 years without eligibility. We'll move to discordant couples, HPV, HIV co-infection, and TB, HIV co-infection. So if you look at our population of 1 million, and in these current guidelines we are doing all this, it makes us think how quickly will we move to treatment-based prevention as a country? Because already by looking at these new guidelines, you find that a large proportion of the people who are HIV positive will already be covered if we reach a good coverage in all these new eligibility criteria. So the timeline for moving to the new guidelines is proposed to begin June 2014, but we are going to apply a phased approach. Like we've done when we first introduced ART in the country, we did it in a step kind of phased approach because we knew that not all facilities can wake up and suddenly they are also providing art services. So in 2003, we had a plan to start with hospitals, big hospitals, followed by smaller hospitals, and then we moved to clinics, which are more in the rural areas. I know there are issues there, ethical issues of who needs to get treatment first, but for us, for the purpose of logistics and easy implementation as a government, that was the best way to do it. So we'll do the same for the new guidelines, and then we will also prioritize. We'll have to begin with the pregnant women and breastfeeding mothers and the children, because we also do have that goal to reach an HIV-free generation. By all means, we're trying to make sure that no babies are born with HIV in the country. So if anything if there will be some delays, we will be at least implementing for the pregnant women and breastfeeding children. And then we're also still not forgetting those below 350 CD4, because they're equally important. But for this one, it's difficult to interpret in Swaziland because we don't have waiting lines. So there's nothing like saying, so in this waiting list, who goes first? So it's a matter of first come, first serve. But otherwise, for the CD4 below 350, we just need to develop strategies to go out and gets the people who are most likely to have very low CD4 counts. And we've seen that it's usually the men. In the studies that we've done, population studies, we found that our men have very low CD4 counts at first HIV testing. And then we are also looking at other enabling factors. Our government is buying all ARVs for the people, so we are not having any donor funding for ARVs. So it's also another uphill battle, but it's not an issue of having no resources, but it's an issue of prioritization. And so as government officials, some of our work is to make sure that government realizes that the need for ARVs is going to keep growing every year until we reach maybe 2020 and so. Unless if treatment and prevention works for us and less people get new infections. So, like I mentioned, then the approach of step-wise design is in line with our rollout process for ARVs. So that means what we will do, those 15 sites that are proposed to be under our study for MaxArt will be prioritized last. In terms of CD4 500, but the good thing with them is that they will already be offering immediate access to us at that time. So there will be there will still be a benefit for the clients who go to those facilities because they'll be getting us immediately, but we will not apply the CD4 500 to some of them. And then we are also, it helps us to respond to the realities on the ground because we have a lot of competing studies that are in the country. So as you can see, all these circles are showing that it's just a lot happening. We have the MaxArt looking at this northern region. ICAP is cutting across between Manzini and Lubombo region. And then MSF is in the Shiseleni region with test and treat and B+, and then there's a study of link for health under Columbia University, which is basically covering the whole country. So it's a little bit of a nightmare, but I think that for our MaxArt studies, to just focus here, we've been able to minimize the overlaps in this area with the link for health. That was one area that we've been trying to deal with. So we can't expand bigger than that as a country. So those are some of the issues that we see. And thank you for listening.
So we're going to switch gears now, and Phil's going to introduce our ethicists and reframe the question.
Yeah, maybe in reframing the question, it has already been reposed, and I think it's really important to keep in mind